I'm going to get started about a topic that isn't talked that much about, but patients may bring it up to you. It's maybe a little bit lower on the list of body contouring desires, but it's something that once you notice it and once you offer it, people may be interested in it. So these are my disclosures, not relevant to this presentation. If you talk about the ideal aesthetic calf, you have to keep in mind after you do liposuction of someone's thighs, the calves may still appear to be big and there may be a little bit of a disproportion. So you may need to point that out to patients as you're doing lower extremity contouring. But the ideal calf aesthetic really depends on the patient. We all may see patients who are more want to be more lean or muscular. And for some of those patients, calf implants may be appropriate, especially for males, bodybuilders. But women want a more lean, thinner calf, or they may want to see some muscle definition, or they just may want the shape to be a little bit different. But one thing that's pretty common is actually what's going on around the ankle. And in the United States, sometimes they call the big ankles cankles. I don't know where they came from, but the ankle fine, and sometimes they can get big enough where it's hard to put on shoes that they like or do things that they like because the ankles are so big and full of fatty tissue. So we'll address that also. If you're going to assess the patient for any kind of lower extremity contouring, first you want to look at their skin. Younger patients with tighter skin are going to get better results. The skin's not going to get loose, it's not going to get dimply. The calf's not very forgiving when it comes to liposuction. The next thing you want to do is look at the fat thickness. And this is where I have an office ultrasound, just a handheld. If a patient comes in, they don't like the size of their calves, I may scan them and show them, look, you're pretty muscular. There's not that much fat. Or I may show them there's actually quite a lot of fat. There's a centimeter of fat that we can improve on. You also want to assess them for their muscle contribution. How much is fat? How much is muscle? Heavier patients may have more hypertrophic calves, perhaps from just the weight they have to carry. So you may want to have them stand on their tiptoes, assess the muscle quality, and tell them what's realistic and what isn't if you're just going to remove fat. A lot of women have lipedema. That's a fat overgrowth disorder. I actually treat a lot of this, which is why I do a lot of calf contouring. But we also got to watch out for lymphedema, fluid disorder, especially if it's asymmetric. As liposuction, in some cases, can actually make lymphedema worse due to scar tissue and lymphatic disruption. It's not common, but it may also not help it in the long run. So you have to really assess the patients for this by looking at the dorsum of the foot and other signs of a lymphatic problem. And you also need to look at asymmetry. It's not uncommon to have some asymmetry, but if it's a significant asymmetry, you may want to look at neuromuscular disorders as to why somebody would be having some perhaps muscle atrophy on one side as opposed to the other. I'll talk briefly about approaches to muscle hypertrophy because those are a little bit different. In the United States, we don't really see a lot of that. But you've kind of got three options from the least invasive to more invasive. You got neuromodulators, denervating the muscle, and then actual muscle excision. I've only done neuromodulators for the calves a few times. It's not that common in the United States. It does require quite high doses of the neuromodulator, which can get expensive. The reductions tend to be pretty modest, but they can last for up to 6 months. There's quite a few publications on there or out there on this. Sometimes just treating the medial gastroc muscle is enough to see a result. Some patients want a more fuller reduction, but it's not invasive. But as I said, the results can be pretty modest. Next are kind of the more aggressive kind of treatments. We'll talk about the denervations, but the actual muscle resections, and these tend to be done more in Asia, where people may have more of a desire to have a very lean calf as opposed to a muscular calf, and it can also be done for major asymmetries. And there's a few different ways of doing it. Some of the reports on this are almost 25 years old now, which can involve stripping of the muscle endoscopically, or it can be an actual muscle resection, which has been shown not to have any functional deficit. It's probably no different than doing a gastroc muscle flap for lower extremity coverage. And you can get pretty significant reductions, especially if the gastroc is what's contributing to the patient's complaints about a large calf and they don't want it to look as muscular. And here are just some examples that are published in PRS, but it's mostly from Asia and Asian patients. There are some scars, especially in the popliteal area, for access to the muscle, so patients do need to be aware of that. But you can see the medial the medial contour of the calf has been improved by resecting the gastric muscle. And just a few other approaches. You can do endoscopic approaches to limit the scars. And here you can see before and after pictures of more slender calves as gastroc muscle's been resected. There's also approaches where you can try to shave the muscle for smaller reductions and obviously for smaller incisions. And so those are the muscle resections, but perhaps a little different way or less invasive way of looking at it is just denervating the muscle. So using the neuromodulator approach, but for a more permanent result. And these are smaller incisions. You need a nerve stimulator for it. Again, I don't have any experience with this because we don't have a demand for the muscle reductions. But through smaller incisions and just dividing the muscle, you can get a reduction in the calf without any gait disturbances. And the patient satisfaction, at least out of one study of 700 cases, is pretty high. And functionally, people don't have a problem, but you can see the reduction in the medial portion of the gastroc after denervation. So just another option to have there. And of course, you can always have combinations of this. You may do denervations, you may do liposuction, depending on what really the patient's presentation is and the assessment of the fat versus the muscle component. But as I said, in America, people here don't really have the aesthetic that we do see in Asia. They're looking for something different. And in America, we tend to see more obesity-related calf complaints. So I'm going to discuss that now for you. And if you look back at liposuction of the calves and ankles, Richard Mladic, one of the pioneers in liposuction, kind of warned us be very careful when you do this because the results were not good. And back then, his conclusions were to use more tumescent fluid. And I agree with this. When I do calf liposuction, I made tumescent a full liter in each calf. I do it until it's very tense. There's a fountain sign, fluids coming out. I use smaller cannulas. Back in the 90s, people were using 4 and 5 millimeter cannulas. I recommend 3 millimeter cannulas. Be very gentle. I have some curved cannulas for this, and I pay attention to the muscle tendon transition zone to contour it properly. Some of the problems that were in a systemic review done about 20 years ago was actually the poor satisfaction. I think that reflects what Dick Mladic taught us also, is because I think it's a technique dependent procedure and has to have high patient satisfaction. Or it has to have very proper patient selection. Problems that you're going to get is, as you know, as you go more lower inferior in the body, you're going to get more oozing, more bleeding, which causes more hemosiderin staining. And that's the pigmentation that you may see after liposuction. It's very hard to treat. Patients hate it. It may not go away. It may take years to go away. And that's one reason I really strongly recommend smaller cannulas, very aggressive tumescent fluid use. And if you do get into any kind of bleeding, stop, reassess, and maybe come back later. Once you get in a lot of bleeding and a lot of contusions, you are at higher risk for having hemosiderin pigmentation. Also, contour regularities. This takes a little bit more work than other areas of the body. This is kind of like the arms also. You have to be, so again, smaller cannulas, be conservative as opposed to being too aggressive. You can also see sometimes ulceration. I've seen ulceration here, again, with too aggressive treatment, and sometimes end hits the cannula, which I'll talk about later, and also persistent edema. Unlike the arms or the upper part of the body, which edema isn't a problem in the lower area, it's dependent. People do tend to swell up more. Sometimes for the first 6 weeks, they may not even see a difference after doing liposuction. And this is, I think, where there's a role for aggressive manual lymphatic drainage. If you're going to do this, you probably want a lymphatic specialist or at least a massage specialist available to help these patients, or you may want to teach them how to do it because they are going to get some edema, and edema can lead to fibrosis. Fibrosis can be very difficult to treat later, and you may not get the result that you wanted. So this is the evolution of my liposuction technique for the calves. In most cases, I just recommend using traditional liposuction, 3 millimeter cannulas. Unless it's a really heavy calf, that's all you need to do. You can even try it with 2.7 millimeter cannulas. A 3-hole Mercedes is fine if you have other variations, but I wouldn't get too aggressive on the tip. Start more conservative before you get aggressive. I've done water liposuction. I don't think there's any benefit to this. I think it's a solution without any problems. So I don't think if you have it, you can use it, but I wouldn't look to this for giving you any better results. Again, laser assisted liposuction. I've done many cases with this role for it in the calves. I think the skin tightening effects of it are minimal. I've used it in other areas. I just haven't found it useful in the calves. And then power assisted liposuction, which I think a lot of us use, is okay to use in the calf if it's a very bulky calf that you're trying to debulk. tell you it's also very easy to get grooves, contour regularities. And if you're first starting off doing liposuction of the calves, don't do it with power. Start off with traditional, something you have more control over. And then once you're comfortable with it, if you really need it, you can do power, but start off with traditional. Some other things, like I said, early cases, and actually for most cases, I try to do all this with a 3 millimeter cannula, or maybe a little smaller if you have it. Add the power assisted or larger cannulas very carefully. You may need multiple access points. Sometimes I can do all this with one or two access points on each calf, posteriorly, and then one or two anteriorly. Sometimes you just need to do the posterior calf. You may need to cross tunnel a little bit. Avoid over suctioning at the access points because there you will see divots. It's not a very forgiving area. And then the standard endpoints that you're going to use for other liposuction, once no more fat's coming out, once it's getting a little bit bloody, do your pinch test. And there's a picture of me doing the pinch test. You can see how thin it is around the ankle because that's where we're trying to get some definition. So around the ankle, I'm probably going to get pretty thin on it to give them the definition. And I'm always with my non-dominant hand, which is always pinching the skin and assessing it, seeing where I am and seeing where there's any areas that need to be treated. And I also just took regular cannulas, curved them a little bit. And what this does is this prevents the end hits. That's imagine the tip of the cannula hitting the skin, pushing it away from the subdermal plexus. And that's where you're going to get problems with possible blisters or necrosis. Because the calf is curved, using a curved cannula, I just found is a lot easier and gives me a better contour. The tumescent technique, if I'm just doing someone's calves, I do all these awake. You don't need to do them with anesthesia. They're just purely awake, no sedation, nothing else. Maybe some nitrous oxide if they want it. Give them some Tylenol or some acetaminophen and ibuprofen beforehand to take the edge off a little bit. Standard tumescent solution, 1 milligram of epinephrine and per liter of either saline or LR. If I'm doing this with full anesthesia, I do put in some lidocaine because it does reduce your narcotic requirements and they wake up feeling less pain. If I'm doing this awake, I'm actually putting much more lidocaine in there. I've actually published a paper on this in PRS. I talk about using 500 milligrams per liter, but really, if you want to do this, you may want to think about 800 to 1,000 milligrams per liter, and this will really make them comfortable. Once it's injected, they're not going to feel a thing. Make sure you put in a little bit of bicarb to take the edge off the lidocaine. And respect that upper limit of lidocaine in your tumescent fluid per kilogram because you don't want them to get lidotoxic. And if you are doing this in your office and you're using higher doses, you may want to have intralipid available to reverse any lidocaine toxicity, which should be rare, but keep that in mind. I used to add tranexamic acid to the IV bags. Now we do it IV. Tranexamic acid, we'll talk about it, but it may reduce the bleeding and the oozing afterwards. If it's awake, we use very narrow cannulas for infiltration of the tumescent fluid. I've got a few small ones, really small diameter cannulas at an infiltration setting, pretty much at the lowest setting possible on the machine because as the skin stretches out, they do feel it. We do offer some nitrous oxide also. And as I said before, I inject until it's a tense, the tissue's tense. There's a fountain sign, there's fluid, tumescent fluids coming out. And then I leave. I have someone stay with the patient. I leave, I go for a full 20 minutes because that's what you need for really maximum epinephrine effects for hemostasis. And really that's what helps with being able to do this awake for the lidocaine to kick in. If you're doing this with anesthesia, I would still recommend at least 10 or 15 minutes for the epi effects. Go do something else, go work on another body part. The calves last so you get really good hemostasis. Just a word about tranexamic acid. It's readily available. It's inexpensive. It's very easy to use. It comes in oral and IV forms. You can put in tumescent fluid if you're doing 1 or 2 liters. But if you're doing a lot of the body, then you can just give it IV, and it kicks in pretty quickly. Tissue effects are up to 17 hours. So usually one dose does the job. If you do have someone who's oozing, maybe that afternoon or the next day, rarely I've had this happen, but I've given them another dose and it seems to clear it up. So kind of keep that in the back of your mind. And there is actually one study that was one pretty good study that looked on it that patients who got IV tranexamic acid as opposed to in the tumescent tissue had higher hemoglobin counts after liposuction. What do we do for VTE prophylaxis? Well, if it's an awake case, it's really not a problem. I don't think you need anything. However, if you're doing this with anesthesia, then how do you put your lower extremity SCDs on? Well, you got to get some modified ones. We do a standard Caprini assessment if someone does need heparin afterwards, we will use it. Usually I start it the next day after I've made sure that the oozing has calmed down. But you can get these ankle sequential compression devices. They work just as well as the calf ones. You just put them on the ankle or below the ankles on the feet, and then you can work on the calves and ankles all you want. And if need be, right at the end of the case, if there's an area that you need to get, you can just take them off and do a little bit more liposuction around the ankles. And then once you're done with the case, patients go in a recovery room and put on the full calf SCDs. And then all our patients early ambulation. We don't have them laying in bed for any period of time. So this is just an example. Usually I'll prep the foot completely all the way down to the toes. If you can get sterile ones, then you can just do it sterilely. Most of them come unsterile. So then I just drape a sterile adhesive dressing over it. So it's outside the operative field, but we can still work all the way down to the ankle and the devices are working. The markings for the patient, this is like a typical patient. I'm also going to be doing a little bit on around the knees. The area in front of the pretibial area, you want to be careful. If there's fat, be very conservative over it because you don't want to expose the bone. That's just going to make it uncomfortable for patients when they hit their foot. And in the posterior area, there's my 3-axis incisions, and you see some arrows where I'm going to actually be doing liposuction around the ankles on both the medial and lateral part. And a lot of these patients do have fat around the ankles. If you're not sure what it is, I have a handheld ultrasound. As I said, you can just scan it and you'll see it's fat. Now you got to make sure it's not a ganglion cyst. That'll feel differently, or if it's any kind of tumor. But if you see pretty much symmetric bilateral distribution of fat, or what appears to be fat, it's going to be safe. If it doesn't feel like fat, you may want to scan it or work that up a little bit more. But generally, it's going to be fat. And here's just me working around the ankle. You can use a 2.7 or 3 millimeter cannula. Patients numbed up pretty well. And you can see I'm working on it. And then in the final picture, you can see I'm doing test, pretty good reduction. Skin is very thin. You can do this awake. It's pretty easy. And so here again, I'm showing how thin you can get with the skin to contour the area around the ankles in patients who've got these fat deposits. And most of these patients are going to probably have lipedema. Here's this is just an awake liposuction of the calf, or I'm sorry, of the area around the ankles. The calves were done also, but now I'm just showing aggressive infiltration with the tumescent fluid. So there's less bleeding or very little bleeding. And then you do your liposuction. It's me using the curved cannula. You can see it's got a gentle curve that follows the calf, and you don't get end hits. My non-dominant hand is over the area that's being treated to make sure I'm in the right plane. And if you get into the muscle, you'll know it's kind of hard to do. The cannula will bounce off of it. So let's show you some examples. Here's a case one. This is a perfect patient. Do it on young, good skin, minimal fat. You can do this awake. She's got a significant calf reduction, both from the lateral and from the posterior views. Here's someone else, young, good skin, a little bit more fat. You can start seeing she's got a little bit of cuffing around the ankle, and that's her afterwards. I did this awake. I did this with power liposuction and a 3 millimeter cannula. You could just as easily do it with regular liposuction. Look how much fluid I took out. I took out 4 liters of fluid. Now that's about maybe 60% fat, so that's about 2.4 liters of fat, or about 1 liter of fat per an ankle, per a calf. You'll be surprised actually as to how much fat can come out from a calf because it's a long cylinder. So it's not unusual to be able to take out 1 liter of pure fat. And that's her again. See a reduction in the calves, skin shrunk down pretty well. So she's got a nice improvement going all the way down to the ankles. As patients get older, their skin doesn't retract as well, and they've got kind of more defined pockets of fat. If you look at the medial area of the calf, just below the knee, there tends to be these fat pockets. She has one on this side, not as much on this side. So kind of keep that in mind. You want to mark those and be a little bit more aggressive. You can see her afterwards. Now, she does have a little bit of that hemosiderin staining over the tibial area that I was talking about. And that is one of the problems when they do bruise. Laser, a V-beam, which may help with that, but a lot of times people either don't have access or it may not help. It's a lot harder to treat later. Here's a little bit bigger cases. A lipedema patient took out 5.8 liters from her calves. You can see a pretty significant reduction, but around her ankle, especially right here, there still tends to be a little bit of residual, either edema or fat that we may need to come back later. Lateral view, you can see a pretty good reduction for patients like this. They're just happy that they can wear clothing that's that's more fitted for them, and there's a pain reduction in the lipedema fat and a posterior view. Here's a mild case. Again, I'm concentrating on the around the ankles and below the ankles, and you can see a pretty decent reduction in the fat in the calves also. And here's kind of a close-up of the area around the ankles, the fat that bothers them. Sometimes it interferes with the shoes they want to wear. There's almost a complete reduction of the fat at the ankle. And just another view, same thing. Here's a much more aggressive case. This patient has lipedema. Her calves are so big that actually makes it hard for her to walk. They just kind of get in the way. Did a round of liposuction with her under anesthesia. You can see a pretty significant reduction in the calves to the point, and actually also I did her thighs, but she can walk better. Her gait is better. She's got better balance. She's not falling over. And that's the posterior view. She could have had more done, but she was happy with it. Sometimes I do this in 2 or 3 stages. Older patients, we can see someone like this, sun-damaged skin. They're not going to get as good a result in terms of tissue contraction. So you got to tell them that. She really didn't care. She was happy just to have smaller calves. If you look on the posterior aspect, the skin's a little irregular. That's just because she had thin skin. It's not going to shrink down very well. So they have to understand that. And again, the reduction in her fat around the ankles. Now, once you start getting into patients with these dimples, you can't promise them they're going to have smooth skin. They actually may be less smooth than they started because it's just not going to shrink down. And so this is a patient, she's happy with the reduction of the calves, but I told her, this is the best I can do with skin tightening. Now, in some cases, they're going to have loose skin afterwards, and you need to do a skin excision. And whether you do a staged one or one at the same time, I'm not going to talk. Well, sometimes it's better to do it all at once. Like in this patient, you can see she's going to have a skin excess, and that's going to end up with edema, and that's going to be another problem. So in these cases, I do the liposuction. This is her after the liposuction. You can see how I'm pinching her skin. That's all going to come out. And I marked about a 13-centimeter width skin excision going from her popliteal down to her ankle. And that's all going to come out. So there you go. There's the area that's being excised after the tissue's removed. And right away, you want to start closing it before it starts swelling. Use lots of towel clips for this. Close her up. And then here's her reduction afterwards. She also had her thighs treated, but there's her calves from the front, from the side, and from the back. You can see there is a scar. It takes a few years for these to start looking good. These don't tend to scar very well at first. Whether you stage it or do it at the same time, I'm still trying to figure it out. I've had some wound breakdown when I've done very aggressive liposuction, and then they swell up and the incisions, the stitches pop open. So if you've got someone with very thin skin, maybe better 6 months later, get rid of the loose skin. You have to be prepared for some wound problems, kind of like the thighs. One important thing when you're doing calf contouring is have a good postoperative protocol. We want them to walk right away, but they got to get some kind of decompression, manual lymphatic drainage, and have good compression. The garments that we use, we get them from Marina. There's lots of good garments, but sometimes you need to order these special Velcro wraps, which will reinforce compression. And so some of the complications, prolonged swelling. Sometimes patients don't see an improvement for 1 or 2 months, so we get them into lymphatic drainage right away. Numbness usually resolves pretty quickly. If they're having excessive pain or discomfort, think about complex regional pain syndrome, or it used to be called reflex sympathetic dystrophy. I've actually had 1 or 2 patients who had that and got them into treatment early, but I've also reviewed one case for a lawyer who was not treated early, and a year later she had significant complications. So pain that's persisting longer than you want, get them in to physical therapy and think about complex regional pain syndrome. Do your routine scar care tape or silicone strips. Remember, they may have contour irregularities. They need to know about them. They may need some touch-ups. And I tell people you may need a touch-up later. If they do get the hemosiderin pigmentation, consider a laser treatment. Worst complications, bleeding, pretty rare, but if you get into bleeding, just stop, elevate pressure, and then inject some more tumescent fluid. That'll sometimes help if the epinephrine constricts it. Infections are very rare in these cases. Watch out for the skin necrosis with the end hits, or if the compression is too tight. I did have a few patients who just were doing crazy things with their compression, and these areas of skin necrosis developed from where it was too tight. Also, if they have lymphedema, I'm not going to get into that, but Wei Chen from Cleveland Clinic, him and I actually talk about this quite a lot. He's got some approaches to contouring and skin excision also, so read his work. And that's it. I'll take any questions.